Thanks, Rolando. For those online right now, if you can hear me, can you put up your hand in the little hand box so I can see you can hear me? I want to see who's tech savvy. Awesome. And by the way, the reason I think the description is even, introducing me, all that really means is that I am moving into this population group. And so maybe it's fitting for me to be here tonight to tell you a little bit more about pain and then the older adults specifically. And then maybe some of my younger colleagues will take care of me one day, because I think as I hear these introductions, I'm just old. That's all it is, right? So to start tonight, the idea is simple. I'm going to run through a quick presentation for you. It'll take us a little bit more than an hour. And then I would like to open up the floor for some questions, and I'll try to answer as many as I can as I work my way through this. So as we get started tonight, I think the first thing is obviously disclaimers, right? We always have to say all our disclaimers. I'll quickly run through these. First of all, as far as disclaimers go, I do publish books on pain. I'm not here to sell them. They are purely for research purposes that we do use for multiple trials. So if you do see a reference, it's just because we use it in a clinical trial. I do teach for a seminar company. I'm not here to sell anything. I'm here to provide a service for the APTA section on geriatrics. And then our research is self-funded. I do not do any work with any pharmaceutical companies, etc. And I think a very important thing tonight that I do want to highlight is the last one, and that is I am not a geriatric specialist, so I do apologize. I would like the audience tonight to listen to what I can teach you about how pain works, but understand that you are the expert. You know your domain way better than I do, and maybe something will resonate with you. We go, wow, that is really neat, and I can do it in a certain way with my clients. So my purpose tonight primarily is, as a pain scientist, to tell you a little bit how pain works and how we're looking at maybe our older patients, our older adults, how they may be having some issues, and how we may be able to help them. Towards the end of the presentation, I'm going to start sharing some specific research we're doing into this area for that matter. And as I said tonight, I don't have anything else to disclaim. And just to be honest and upfront on a nice Tuesday night for you, I did recently attend a conference, and I want to disclaim I got a cup of coffee at the Pfizer booth. And so I just want to make sure people know I did that. And I didn't get anything for it, but I did get a cup of coffee from them. So let's start at the beginning. Everybody here tonight in this presentation should understand that we as a population in the United States, and globally for that matter, is getting older. Jokingly tonight, I could probably say if you don't know this, you probably shouldn't be here tonight, right? If you have an interest in geriatrics, you have an interest in our older population, it shouldn't be lost on you that our population is getting older. And what this means is it's going to be unique in terms of challenges for us as therapists. But also for me, actually, I'm looking at this as a great opportunity to serve people better and more. When I talk to younger students at commencement speeches, they're very concerned about the future and the future of therapy and the student debt, etc., which we can have a long conversation about. But I always look at these slides, for example, and thinking there is ample opportunity for us in the future to take care of people. And so I do look at the aging U.S. population not only as a concern in terms of some issues we may have to deal with, but also what a wonderful opportunity for us to reach out and truly impact people's lives and quality of life. It shouldn't be lost on you tonight, and I don't want to really spend a lot of time on statistics or epidemiology, but our older population also have pain, especially persistent pain. It's a major big deal for them. Pain is a universal human experience. We find it in children, we find it in adults, and we find it in older adults. It shouldn't be a major newsflash for us tonight, and we know that this is occurring. So again, we're getting older, and our older patients do struggle with pain. We know that. Bottom line is pain interferes significantly with life. We know that there's lower quality of life, reduced function, increased incidence of depression, greater fall risk, by the way, higher chances of being institutionalized, and the list goes on. And hopefully, if you are a geriatric specialist tonight, at this point, you're probably yawning, going, I know this. I've been to all the conferences. So this is easily established, but just so we know where we're coming from in this regard. What I do want to talk about tonight is a little bit moving us towards what patients want from us. Now, this has been studied quite extensively in a variety of settings, But it's interesting, if we look at various qualitative studies, we go to people and we ask them, what do you want from us? It's very well established, and there's this body of evidence that's being built together. So let's have a quick look. They want to know what's wrong with them. The diagnosis, what's wrong with my knee? What's wrong with my back? What's going on with my neck? They want education. Basically, they want information. We know that. What's very neat for us, they want personalized care. So I'll give you an example. The chronic pain epidemic is not lost probably on most therapists. Right now, a lot of people are struggling with chronic pain. And we always thought it'd be so easy to go to a big city, fill up a big auditorium or a large football stadium, put 80,000 people in there, teach them how pain works, and they all go, I got it. And then suddenly 80,000 people are better, and we just move to the next 80, the next 80, the next 80. The problem is it doesn't work that way because pain is an individual experience. I have done numerous evening talks at support groups, at conferences, etc., where patients are, and they'll come up to me and say, that was a great talk, but let me ask you about my pain. So people want personal care. They want personalized care for their specific condition. They want prognosis. How long will it take? Can it get better? Will it get better? Which is intriguing for us to think about, especially for the older adult. There's almost that sense of, well, I'm old, so things must get worse, right? Well, from a neuroscience perspective, that's not exactly true, especially when you look at things like neuroplasticity. Explanation, what are you going to do with me? They want relief of their pain, otherwise they would not come and see us. And then very neat for me as a therapist tonight, they want a thorough physical exam. They want to be physically examined or touched, if you will, in a therapeutic manner. I think this is important because if we truly want to impact our patients, we must know what they want. And so what does this have to do with us tonight? I want you to look at that list and understand between all of that, either explicitly stated or inferred, they want information, they want education. And it's interesting because in our profession, we don't really even have a code for education, right? We cannot code for education, but yet people want to be taught what's going on, how long will it take, what can I do, what can you do, all those kind of neat things. The bad news is that a lot of the language we are currently using in therapy is very catastrophic. It's very bad. The saying of words that harm, words that heal rings very true for our older patients. We know that terms like wear and tear, deterioration, disc space, crumbling, collapsing, all these things are very, very scary for our patients. Interestingly enough, the studies have shown us not only does it not help, right? Frank walks in our clinic, he can barely bend forward, and I tell him he's got degenerative disc disease. Not only does that not help him, but it actually makes him more fearful. So for those of you tonight that are listening to this and you happen to have a pen or a piece of paper with you, which means you're just like me, one of the oldies, right? Guess what? I want you to write down this beautiful quote. 1993, Pain Journal, the late Gordon Waddell. The fear of pain is worse than pain itself. You've heard this before probably, right? 1993, Journal of Pain, the fear of pain is worse than pain itself. You and I, every day in the clinic, treat people. They have pain, but maybe not even that much, but they're so afraid of pain. Think about the patient that walks in with a knee replacement and they barely want you to touch their knee. They're already afraid before you even get to talk to them. Interestingly enough, we know that asking people pain ratings make their pain worse. If we ask you 3 times in a row, what's your pain, what's your pain, what's your pain gets worse because as you'll see a little bit later on, the brain gets very busy with various aspects of the pain experience, and this so-called circuitry, which we now loosely refer to as the pain neuromatrix, this mapping actually lights up under our scanners when we see it. So again, we tend to go to people all the time. Remember, Joint Commission and Blue Cross wants it and Medicare wants it. We often have to ask them, what's your pain, what's your pain, what's your pain? So just be cognizant at this point, at least, that some of the day-to-day stuff you and I do actually may make people worse by just the words we're speaking. But I want to show you something even more intriguing. This is an amazing study done a couple of years ago by Dr. Alison Ledgerwood. I want you guys to watch this carefully. They went to a city in California for Rolando's case, let's call it San Francisco tonight. They went to a city and they basically brought 100 people off the street and they put them into 2 groups, 50 in one room, 50 in the other room. And I'm making up these numbers. I'm just explaining this study. I don't have the exact numbers in front of me. But anyway, they took people into 2 rooms. They went to the first group and they said, hey guys, there's this really cool new surgical procedure that is on the market. And they explained this new procedure the surgeons will be doing in this area. But for the one group, by the way, they focus on the positive message. This surgery is amazing. It is a 70% successful operation. In the other room, by the way, they talked about the same surgery, but they explained that this surgery has a 30% chance of failure. So the message was shifted towards the negative. Lo and behold, when people walked out of the room, they surveyed them about the perception of the operation. And no doubt about it, people that got the positive message thought this is a great operation, and people got the negative message that this is a terrible operation. After some coffee and cookies and having some downtime, they brought them back and then they flipped the messages on them. Now they went to the group that got the positive message and said, now you guys understand it's 70% successful, but that means it fails 30% of the time. So they shift the message from positive to negative. In the other room, they did the same thing. Now, I know we told you guys this is 30% unsuccessful, but you need to think about it. It's 70%. Bottom line is, afterwards, notice this. Notice the right-hand side. The minute you move negative, you cannot be shifted that easily. Notice on the left-hand side, when you went positive message, you shift to a negative viewpoint of the surgery. The point being that you start seeing life as the cup is half empty. In the pain world, we refer to this as pain catastrophization. Woe is me, life is over, bury me now. I get spinal degeneration, I'll never be able to, and fill in the rest of your sentence. And please hear me tonight, I'm not making fun of those statements. I treat those patients, I see them all the time. It's just we all speak tonight in therapy language and we hear it. The point being, if we use very bad language in therapy, we tend to shift people to the negative. Why is that important? Because the minute you shift negative, the brain dries up our happy chemicals. Our naturally occurring enkephalins, endorphins, serotonin, cannabinoids, etc. gets turned off. Do you know that the brain produces opioids 50 times more powerful than what you can find in an emergency room tonight? As I always jokingly say, the most powerful pharmacy in the world sits between your ears. But what happens when we start bombarding people with negative, 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 what happens, the brain starts seeing the world as negative. The cup is half empty, and it dries up these chemicals. And we tend to do this with all kinds of patients, not just our elderly patients. We do this with anybody that experience pain. We have a knack for this because we were trained this way. So we often hear this, right? And I've heard this for many years. And as I mentioned tonight, you are way more qualified than I am tonight, probably to do this seminar. But for many years, I've had patients walk and say, my back hurts. But what do you expect? I'm 87 years old. Well, without trying to fill the whole slide with 100 references, we need to know the following things. There's very strong evidence that proves pain is not normal with aging. Pain and aging is two different things. And I'll show you in a minute a great example. I think that's a great way to start, because if we think that aging and pain is the same thing or synonymous, then there is no hope for our older patients, and that is absolutely false. By the way, we do know that pain is due to a specific disease or a pathology that's maybe underlying. And each patient, by the way, age is different. I'll give you a great example. I mean, I'm 5 years younger than my wife, but guess what? She lives every day like a 28-year-old. She's excited, she exercises, she's fit and healthy, and I'm the old guy that sits in a chair working all day and research. And my kids laugh all the time. Dad, you're younger than mom, but you act way older. And the point being, just be careful of these normative values. I think everybody's aware of that. And then very important for me and you as a therapist tonight, most of the changes we see in our older patients come primarily from inactivity. They don't move. And last time I checked, as a member of the APTA, I sell movement every day. I'm a movement salesperson. Or as I tell my students, we're the used car salesman of movement, right? Come on down to therapy, we'll give you movement. And if you come in the next half an hour, we'll give you double movement, right? How cool is this? This is amazing as a therapist. I'll give an example. This is really cool research, and I want to show you this. Dr. Lance Toomey, Nikolai Bogduk, and Taylor in Australia showed us that our lumbar spine, our low back, starts aging in our early 20s. Most of the studies showed that early age changes occur at age 22 to 23. By the way, if that's shocking news to you tonight, relax, take a deep breath. Welcome to the human race. Happens to all of us. It's a normal occurring process. Now, from age 20 to 30, we get older, right? Absolutely, from 30 to 40, 40, 50. What you're seeing in the green is just a normal age curve. As we get older, if we can measure the age changes in your spine, that's what you're seeing. So this is a normal curve. So I can probably ask you, and I want you to reflect on your side and the other side of the screen, at what age back the most common symbolizes. Can you guys hear me now? Again, I'm going to ask just so I can make sure the sound is good. Can everybody, can you put up your hand if you can hear me? Good. No, I just need to mute, I think. This is normal age changes. Everybody see this graph, correct? From 20 to 30 to 40 to 50, we get older as we get older. Fair enough. Now, at what age is back pain the most prevalent? Well, back pain is the most prevalent, by the way, roughly between age 35, 40, 45, and 50. What you're seeing in blue here is basically how people show up in therapy. The largest percentage of people with back pain is in that 30, 40, 50-year olds. There's no correlation between back pain and aging. And this is important because if I believe they're the same thing, then it's basically a certificate telling me as you get older, you're going to get more back pain. And there's really no research to back this. And there's a lot of these kinds of studies out there. How about the old Rotary Cup, right? All of us have seen the Rotary Cup, and we've had patients walk in. We now know that 1 in 3 people over the age of 30, if we scan you today, have significant anomalies and age changes on the MRI. Over the age of 70, 2 out of 3 people have it. So all I want you to understand, there are lots of these normal age-related changes, and they may or may not correlate to pain in our patients or decreased function. How about knees? How many patients come in and say, but you don't understand it, I got arthritis in my knee. Well, we now know that there's about a 50% correlation between arthritis and pain when it comes to the knee. What does that mean? If we took 100 people at random off the street today and we scanned all 100, 50% of them, no pain, life is awesome, have arthritis. And again, arthritis and pain is 2 different things. And better yet, a third of collegiate basketball players have significant age changes on the knee. I think the bottom statement is probably going to shock most of you, but the study done by Riddell in 2014 showed us about a third of knee replacements in the US may even be unnecessary. Again, I'm not having a go at anybody tonight. If you're a surgeon, if you're a doctor, no big deal. I do these at medical conferences too. There's just good data to show us, again, age and pain are 2 different things. And I want to teach you tonight a little bit actually how pain works, if that's okay. Now, the aha moment. Now, what is this talk about tonight? And this slide truly would solidify and explain to you what we're doing if you want to follow me real carefully here. Do you know that in every single day in America, about 140,000 people attend outpatient physical therapy for low back pain? I'm going to say it again, just because it's a really big number. But every day, about 140,000 people come to outpatient therapy for low back pain. We then spend an enormous amount of time telling them everything you can about their back. Your story may sound something like this. This is a picture of a good disc. This is your disc. This is a picture of a good spine. This is your spine. This is a good muscle, bad muscle. So we contrast good versus evil. The problem is just, why did they come and see you? They came because of pain. And who you're seeing here at the right-hand corner at the bottom is Louw Gifford, one of the most unsung pain heroes on the planet. Physical therapist from England, unfortunately passed away a few years ago, was the first guy to really figure out this idea that when people come to us with low back pain, we teach them everything about the low back, but nothing about pain. Did you get what I just said? People come to us every day with shoulder pain, and we teach them everything we can about the shoulder. This is your rotator cuff. This is your glenohumeral joint. This is your AC joint. There is a lot of space. There's not enough space. But we teach them nothing about the thing that brought them into your department or why they're seeing you. That's pain. So what pain science, pain neuroscience really is about is teaching people how pain works. Not the back, not the neck, not the knee, not the shoulder, pain. So the question is now, how does pain work? Well, this is tricky, and I don't have a lot of time tonight, so I'm going to do it real fast and give you a fire hose approach to understanding a bigger picture of pain, if that is okay. Here we go. The best way to understand it is this little drawing. It was drawn by Louw, the same gentleman I just showed. In 1996, he drew it. It was published in 1998. We call this the mature organism model. Don't worry about the big name, but this is what we consider the bigger picture of pain. So first, let's start with tissues. Tissues do get injured, no doubt about it. If you didn't know that, you probably shouldn't be here tonight. Ankles do get sprained. People do hurt their shoulders. People do fall off ladders. People do slip on the ice. No doubt about it. Tissues do get injured. But that's only one piece of the puzzle. For too long, we've only looked at tissue injury and pain as being the same thing. Remember, injury and pain is not the same thing. There are many people get hurt and they hurt their tissues, I should say, but don't really experience much pain, or vice versa. We have people that have enormous amounts of pain, but their tissues are healthy on the scan, the X-ray, the MRI, etc. So let's start with a simple discussion tonight. If you sprain your ankle right now, would it hurt? And many of you may have heard me talk about this at many conferences, CSM, etc. But the answer is obviously, well, duh, sure. If you sprain your ankle, it would hurt, Adriaan. What kind of therapist are you? Where were you trained? Africa? Well, actually, I was, but thanks for asking. The point being simple. If you sprain your ankle, it would hurt, no doubt about it. But imagine tonight, when you're done with this webinar, you decide to go out with your friends. As you walk across a busy street, you roll your ankle. In the middle of the busy street, in that split second you roll your ankle, you see a bus coming straight for you. Does your ankle hurt? And the answer is no. Why? Because there's a bus coming. And what do? You shut the ankle down. We use very powerful enkephalins, endorphins, serotonin, and opioids to shut the ankle down. Now listen carefully. You run on a sprained ankle across the road. Don't feel the ankle because a bus comes by. Then when you reach the other side of the road, guess what? You feel the ankle. Why? Because the bigger threat is gone. Pain is produced by our brain based on perception of threat. Simply stated, if you're crossing the busy road and you roll your ankle and that bus is coming and I was running right behind you and I can put a stethoscope on your head, your brain would have to make a decision. Ankle sprain, bus. Ankle sprain, bus. Who wins? The bus. Because if the ankle sprain wins and you feel pain, the bus will flatten you. So what does the brain do? It shuts the ankle down. The bigger threat, in this case, the bus wins, and we run across the street on a sprained ankle. Now that the bus passes by, the brain makes a different decision. Ankle sprain, sidewalk. Ankle sprain, sidewalk. Are you okay with that? You understand pain is an output, a decision by the brain. Let me show you this. Our eyes contain light receptors, not vision. You don't see with your eyes, you see with your brain. Your eyes bring light in. It projects it to the back of the brain, flips it upside down, and we create vision. It's a brain construct. Our ears contain vibration receptors, not hearing. You don't hear with your ears, you hear with your brain. Very important for me and you as a therapist tonight is that our tissues contain nociceptive receptors, not pain. There are no pain fibers in the human body. The only thing your ankle can tell you is danger, threat. Danger, danger, you sprained your ankle. Danger, danger, there's inflammation in your hip. Danger, danger, there's a bulging disc at L3. But it cannot tell you pain. Pain is a construct of the brain. When the brain gets enough information, it may make a decision to produce pain to get your attention. The point being, very simply, pain and injury, two different things in our patients. All right, moving on. Tissues get hurt in environments. Imagine spraining your ankle at a football game where your team is winning, or doing it when your team is losing. The point being, environment can modulate our pain very, very powerfully. 3 scenarios I don't want you to ever forget in your life. Number 1, if you hurt yourself in a high stress environment, your chance of chronic pain increases rapidly. So think of your higher stress environments, things like war or combat, right? Surgery is an example, or car accidents. Those are very high stress scenarios, work environments, etc. Sports alter pain depending on the context of the game. Are you winning or losing? Good research there. Demolition derby drivers. Studies have shown us demolition derby drivers crash in an evening 50 times. They whip their neck around at 25 miles an hour, which is way beyond the speed needed to damage tissue. But yet very few of them actually experience neck pain. Again, an environment that they're in, they're having fun, they're expecting it. But just to make you understand, when somebody sits in front of you with pain, the environment in which they hurt themselves very powerfully drives this. In our older patients, we need to start thinking about social isolation. We need to start thinking about loss of a loved one, spouse maybe passing away, being in a nursing home away from a home. These environmental factors are very, very powerful when it comes to pain. Now, notice in the drawing, we've got tissues, environment, but I told you a few minutes ago, it comes from the brain. So we got to fire information into the spinal cord, and for that, we use our nervous system. The next system that plays a role in pain is your peripheral nervous system. We often refer to peripheral neurogenic processes. Here's the most important part of this slide. Your nervous system is not a passive bystander or a plastic tube that just sends message from A to B. Your nervous system can ramp information up or even calm it down. It can act as an amplifier. We now know during injuries, when there's inflammation, when there's immune responses, the nervous system can actually start ramping up. We start getting things like neuroinflammation, increased immune activity with macrophages, T lymphocytes, and cytokines. That's been linked to things like demyelinization, axonal loss, and then increased ion channels or receptors. Don't get too worried about this on a Tuesday night webinar, but I just want you to understand that your peripheral nervous system, when it gets information coming in and firing it into the dorsal horn, it can actually ramp the system up even more, where the nervous system becomes a significant amplifier of information. Once that information comes into the central nervous system, it enters into the dorsal horn. Now, in the dorsal horn, if you knock hard enough and long enough on that door, bang, 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 there are permanent changes that occur. We now know significant firing via C fibers. High levels of amino acids are causing changes in the chemistry as well as the neural contact in the dorsal horn. Some of the synapses, some of the interneurons actually start dying out, etc. Long story short, if you bombard the periphery long enough and hard enough into the central nervous system, your inhibitory interneurons, the ones that your gatekeepers that block the information, they actually start dying out. So what happens in your patient? The gating that stops information gets lifted from the periphery. Now things that shouldn't typically bother the brain becomes a little bit of a nuisance. C fibers start pulling backward or out of that area, and A fibers grow in, specifically light touch fibers. So you and I may start getting something we call allodynia, where light touch now activates a lot of the circuitry associated with pain. Upregulation of second order neurons. So now we start getting more information firing towards the brain. Inappropriate synapsing. Other levels of the body starts feeding in. Now pain feels like it's spreading. Immune system. This list goes on and on and on. Now we start getting immune function changing. We start getting changes in motor activation. By the way, one of the things that occur in chronic pain is the blood-spinal cord barrier opens up and information can pass from left through to right. And now patients are saying things like mirror pains. I get pain in my left elbow, Adriaan, but I'm getting the same in my right arm. What's going on? Your immune system starts mobilizing and opening up these pathways. And ultimately, the brain cannot produce these happy chemicals. Again, the last thing I wanted to do on a Tuesday night is giving a heavy neuroscience lecture, but I want you to understand that much of what you see in chronic pain, things like light touch is very uncomfortable, allodynia, pain that spreads, pain that is bilaterally distributed or widespread distribution. All these things you see in clinical practice, we can explain in real-time biology and physiology. They don't make it up. This is very well documented, very well described. So when patients tell you things that don't fit, it doesn't fit the textbook the way you and I were taught in school. I want you to know there's good research to prove it can do it, and it does it in our patients. If we fire hard enough and long enough into the brain starts having a meeting. In 2001, one of the most incredible articles were published by Professor Ron Melzack, where he talked about this meeting in your brain we refer to as the pain neuro matrix. So you and I were taught or think of pain often as a single activity. If I were to punch in the arm right now, there'd be an area in your brain that lights up and basically like a little light bulb going off. Adriaan's a jerk, Adriaan's a jerk, Adriaan's a jerk. Hold the lawyer, right? That's not how it works. We now know if you stub your toe, if you hurt your knee, if there's arthritis in your hip, and it fires into the central nervous system, the brain starts having a meeting. What you're seeing here is a brain scan of a young girl we scanned. She's 34 years old. Sorry, she's 31 years old. And no, don't worry, it's not an elderly patient. But my point being, when she does an anterior pelvic tilt or she arches her back, she gets horrific pain. And by the way, it's okay. It was clear this is not a big deal. She wanted to do it. She's a professional dancer. But what I want to show you is all these red blobs. When we put somebody in a brain scanner, these blobs in an fMRI picks up oxygen and blood flow. It just tells us there's a lot of activity going on in an area in the brain. And all I need you to see in this slide tonight is look at all the red. There's not one dot. The whole brain gets very, very busy. And very simply, all it is, it ends up looking like this. There are 9 areas in the human brain that becomes very busy during a pain experience. Now, that's intriguing because these 9 areas do not relate to back pain, neck pain, knee pain, shoulder pain. It doesn't matter where the information is coming from. The brain has a meeting. Very simply, the brain says there's a threat and I need to have a meeting about it. These 9 areas, by the way, have other jobs to do. And when pain comes along, guess what? It hijacks these areas. Think, for example, about the premotor motor cortex. When pain comes along, that area gets busy. So what suffers? Motor control, fine motor control, planning of movement. So these patients struggle to move because their brain is currently in a pain meeting. The anterior cingulate, focus and concentration. If you've been around pain long enough, you'll know about the fibromyalgia fog or the whiplash fog, where people have these fog. They cannot remember things as well because the anterior cingulate, by the way, that helps us focus and concentrate is very busy with pain. The prefrontal cortex, problem solving, memory, analytical tasks, numbers, appointments, they become complicated because guess what? The brain is in a pain meeting today. Amygdala, the area that controls our fears. If I were to do a very light manual technique on your back right now, it's the amygdala that will analyze this and says, oh, Adrian's just doing a nice light little technique on my back. If I press really hard, strong technique on your back, it's the same area that say, ooh, that's pretty strong on my back. Now for therapists, we may grade these as grade 1s or 2s or 3s or whatever it may be. In a person with chronic pain, that area gets so busy with pain that when I do a light technique on your back, the brain interprets it as a strong technique. And I'm hoping some of you tonight will sit and go, whoa, that makes sense. You know, I can barely touch Frank's shoulder or Susie's arm because the brain is busy with pain. It cannot interpret normal information. The sensory cortex, where did that information come from? The hypothalamus and thalamus that regulates things like body temperature, food, how much we eat, sleep, all those autonomic functions we have to deal with. Cerebellum, balance, proprioception, movement, cognition, hippocampus. And the hippocampus especially is important because it deals with memory. In chronic pain, people struggle with short-term memory. The long-term memories are typically laid down in the brain. But long-term, the brain will start struggling with these short-term memories because it cannot lay them down. It's too busy with the pain meeting. Now, to make it even more complicated, guess what? These 9 areas in the brain now will start meeting with all the other areas in the brain, and these maps become ingrained. Now this map will start linking with maps that deal with memories, maps that deal with beliefs, sounds, anxiety, smell, sight, etc. Previous physical therapy experiences. You know, maybe they've had bad experiences, and now the minute we say, you're going to see a physical therapist today, it lights up this map and the whole brain lights up. And no wonder that person is so nervous when you walk into the treatment room. So I'm hoping at least on a simple way tonight, you can sit there and go, wow, pain is way more complex. And that's probably what I'm trying to show you tonight without trying to get into deep neurophysiology on a Tuesday night after probably a long day in the clinic. And then finally, to complete the pain circle, whatever comes in gets processed and then there's an output. When we are faced with a stressor, and we typically use a lion metaphor, but pain is a stressor. I want you to understand tonight, pain is normal. Without pain, you'd be dead. But living in pain every day is not normal. That's a stressor. If you live in pain every day, what happens? You start getting a massive influx of some of these stress chemicals like cortisol. Cortisol activates your immune system, more cytokines. And by the way, cytokines is what then travels throughout your body that gives you widespread fatigue, sensitivity, sore, ache, very similar to what we see with the flu. But long term, guess what? If you change some of the cytokines in your system, it leads to problems with memory, focus, concentration, etc. So the point is being pain is really, really, really complex, right? Fair enough. Good news. You just passed the crash course in Pain Neuroscience 101. And again, I apologize. I know you're probably sitting there going, whoa, 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 wait a minute. I just need you to understand tonight that pain is way more important than just you hurt your back and now you get pain. There are many processes going on in the human body that drives a pain experience. So let's go to the clinic because I think that's why a lot of people often show up for these classes or webinars. This is all cool, Adriaan. Way to go, science geek. But what do I do in a clinic? Well, let's go there. So the last 20 years of my life is summarized in this little picture here. Very simply, we've learned an enormous amount of how pain really works in a human being. There's a lot more, by the way. And taking that information to our patients. It shouldn't be lost on you right now in the midst of the COVID pandemic, that we also have a pain and opioid epidemic. Actually, I just this afternoon, about an hour ago before this, submitted a paper that I was asked to write, and that is the post-COVID-19 pain tsunami. There is a lot of concern that chronic pain will get drastically worse with the immune responses, the inflammatory responses, social isolation, depression, etc., etc., etc. Bottom line is there's a big amount of work ahead of us from here on out. So we've taken this really cool science, the stuff I tried to explain to you in a short amount of time, to our patients. How does it work? So we make pictures, and I'll show you in a minute how they look, but we very simply use pictures, metaphors, drawings, and we explain to people how pain works biologically. How do we do it? One-on-one. I sit across a patient's table or a plinth and explain to them one-on-one, hey, Frank, this is what's going on with you and why you hurt. We can do it in groups. We put groups of people together. These are very successful in hospital settings, in the VA, Department of Defense, etc. And now also even with telehealth. During COVID, there was a massive upswing in telehealth. And guess what? Therapists were very successful in being able to explain to people how pain works via these telehealth platforms. Good news is we already have a script. What should we explain to people? The list you're seeing there on the right-hand side is basically what the science is telling us. And it's everything I just showed you, don't worry. It's how the physiology of pain works neurobiologically. Nociception, information pathways, neuron synapses, where they talk to each other. Action potential, where the nervous system starts ramping up. Spinal inhibition and facilitation, meaning the ability to calm things down or ramp it up. Peripheral sensitization, where the peripheral nervous system ramps up. Central sensitization, where the central nervous system ramps up, but then also the ability for things to restore. There's plasticity. You mean this doesn't have to stay like this forever, Adriaan? No, ma'am. This can change. The most powerful thing you can give a patient is hope. And I will tell you right now, in the world of neuroscience, neuroplasticity has never been this alive. The brain is plastic. You have 80 billion neurons in your brain. You have 125,000 miles of wiring, cabling in your brain. By the way, that gets replaced every 3 weeks. Wow, how cool is it? Do you know that even in your 70s, 80s, 90s, and beyond, you grow 1,000 neurons every day of your life? It's plastic. You know what that means for me as a pain scientist and a pain clinician? This can change. And that gives people hope. You mean I don't have to be like this forever? No, ma'am. It'll take work, no doubt about it, but it can get better. No doubt, in my mind at least, when it comes to the neuroscience of pain. Now, we've done a little bit of work in the last couple of years on who actually needs it. Not everybody needs it. If an acute ankle sprain walked in our clinic today, they probably don't want me to spend the whole session just explaining to them how pain works. Hopefully I do something for their ankle as well. But who really needs it? I'll just quickly give you the list because it's a little bit newer. We've been working on some of these things. First of all, the patients that need it would be people that have central sensitization. This is where the central nervous system ramps up. Easily, they have widespread sensitivity all over their body, right? People with chronic pain, pain that has been there for a long time. People with high levels of fear, people that are very afraid and nervous. People with catastrophization. The easiest way to think of catastrophization, they've kind of given up. Now, we can measure these with very deliberate scales like the Fear Avoidance Belief Questionnaire, Tampa Scale of Kinesiophobia, pain catastrophization scales. But for a clinician, just be looking out for that person that's nervous and anxious, they're afraid. and then people that have kind of given up, if you will. And then very important, even now lately, we've got some good research for acute pain. It may be quite helpful, but then also people that want to change. What's very important for me is for you to understand that it sounds bad when I say it, and I apologize. Not everybody is ready to change yet. It doesn't mean they don't want to change. They're just not ready for change. In our modern world, it's kind of the old, I'm fat and happy, or I'm a smoker, I'm okay with it, leave me be. When people walk into our clinics and we got to work with them, but they're not ready to shift, a cognitive intervention won't work. What I'm trying to say is you can do exercise with them. You can do normal movement-based therapy, but trying to change how they think won't work because they're not ready. They're in the pre-contemplation phase. For me, again, as an outpatient therapist, it may sound something like this. I'm only here so the doctor will give me my medicine. That's the only reason they're here. I'm only here to keep my wife off my back. I mean, no disrespect, but I hear these stories all the time. That tells me they're not ready for change. They kind of have to be here. I'm only here because work comp sent me here as an example. It's when they move to the other phases, the contemplation or the planning or preparation phases, they tend to do better with cognitive type of interventions. So how does it look? How does this thing look that we keep talking about pain neuroscience education? So let me show you in a clinical scenario. What we've done in the last 12 years of research now is we've built a series of different stories or metaphors. Patients don't learn through factual information. You don't learn that way either. So how do we learn as human beings? We learn through stories. We have built 48 stories as of today for different research projects, but we basically sit with the patient and tell them a story. People remember stories. So since everybody is still listening, I'm hoping, I want you to put up your hand if you can remember the story of the tortoise and the hare. Can anybody remember that story? Let me see if I can see some hands going up. There we go. Yeah. Why do you remember it? Because it was a story. You remember stories. Now, I don't want to put anybody on a bad spot here because some hands remain up, but how many of you guys can remember what you were taught about history in third grade? Now, you can lie to me, right? Hitler or Lincoln or whatever you want to call it. We don't remember facts. We remember stories. So what we've done in the last so many years, we built stories on pain. And all I want to tell you tonight is we've got great research, I'll show you in a minute, that shows us if you explain to somebody how pain works in a story and they can remember the story and listen to the story, their lives actually get better for it. So the classic story, the best story we've got, and when I say the best, it means it's the highest ranked one by patients in all our clinical trials, is the alarm story. So we will metaphorically explain to somebody that their body has a living, breathing alarm system called the nervous system. And our alarm system monitors for things throughout the day. When life is good, it's just buzzing along, enjoying a beautiful day. If you step in a rusted nail, the alarm ramps up. Ding, 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 there's a nail in the foot. If you hurt your back, ding, 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 the alarm goes off. Your nervous system works like an alarm system. That's the metaphor. So what you're seeing in this simple graph here on the left-hand side, before you develop pain, your alarm system was buzzing along, enjoying a beautiful day. Notice it gave you lots of room to do stuff. You could walk a mile. You could sit an hour in front of the TV. You could stand for 20 minutes to cook something in the kitchen, or you could even deal with some stress at the office or stress at home or with some family members. But then something tripped the alarm system. You hurt your back. You had surgery. You had maybe an emotional time in your life. The alarm went off, ding, 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 ding. And then we do something about it. If you step in a nail, what do? You pull the nail out of your foot. You get a tetanus shot, put a bandage around it, and life gets better, right? The alarm goes down. If you hurt your back, what do? You maybe go to the emergency room, your family doctor, you go to physical therapy, they treat it, and it gets better. But we now know, and this is the neat part in blue, in about 1 in 4 people, the alarm system comes down, but not all the way down. And this leads now to an extra sensitive alarm system. And now notice how much space you have to do stuff. This picture I'm showing you right now is the biggest aha moment that our patients have. And again, I'm not trying to sell you anything. I'm just showing you something neat. And I would highly recommend, again, we published this in a paper. It's easily accessible. These little graphs, we've done them. I'm not trying to, it works. What you're seeing here is a clinical example, a metaphor for something you and I call central sensitization, peripheral sensitization, hyperalgesia, or allodynia. Before you had pain, you could do all these things. Since then, you've got this. And this is where they get the aha moment. Oh, no wonder I cannot do X, Y, or Z. Notice we shift them away from the rotator cuff, away from the knee, away from the back. Now, they may say, yeah, but you don't understand that the scan said I got arthritis. And then we talk to them about how arthritis and pain are not always the same thing. I'll show that to you a little bit later on, how we actually do that in some of our research as well. Now, in all the years we've done this, people ask us often, but why did it stay sensitive? So now we may start bringing in what we call yellow flags. Remember, green means go, red means stop, and yellow means be careful, right? Caution. So in our patients, it may be things like loneliness, medical tests, labels, diagnoses, fear of the unknown, medical costs, loss. It's these psychosocial stressors, getting a different diagnosis, or your pain lasts, treatment's not working. As long as these stressors go on, I cannot tell you how many times I've drawn this little alarm with patients. And I say, hey, Susie, if you go from therapist to therapist to therapist and treatment's not working, will your alarm system calm down? I've never had a patient say yes. They say, no, it'll stay up. Exactly. Hey, by the way, if you live in pain every day and you're not getting any help for it, will your alarm system calm down? No, it'll stay up. Have you noticed how supportive your family may have been in the beginning, but how this has put a strain on your relationships? And I mean no disrespect, but this is often when I see mascara running. Yeah, my daughter has to take a lot of time off work to drive me to appointments. And I know this is hard for her and the kids. Guys, this is real stuff. They got it. They understand it. And by the way, I often ask them, what else do you think in your life keeps the alarm elevated? And that's when they start telling you things they would not have told you in visit one. How many times have I had a patient tell me, well, I didn't tell you, but I'm separating from my husband. These are very deep personal things that they now start bringing forward, which you and I now know powerfully impacts their pain. The number one question I get, however, is, Adriaan, how do I turn the sensitive alarm down? The cool thing is there is a ton of stuff you and I do every day in therapy that calms the nervous system down. Knowledge, information, aerobic exercise, getting blood pumping through the body, relaxation, meditation, diaphragmatic breathing, or any kind of breathing for that matter, pacing, great exposure, the list goes on and on and on. So we use our therapeutic modalities not to fix things or to undo a bad joint, but to dampen the system back down. And that is the essence, basically, of how we would explain therapy. Notice I still do the same stuff everybody else does, but my paradigm has completely changed. Now the question, and it's kind of a silly question to ask about, 50 minutes into the lecture, right? Does it even work? Well, yes, it works. And it's not because we're on the papers and we did the papers, we just did the research. Here's what I want you to know tonight. When a patient has pain for quite a while, and we explain to them how pain works and they get it, as we often say in the marrow of their bones, they go, I got it. Guess what? Their pain goes down. They move better. They function better. Their fear goes down. Their cup goes from half empty to cup half full. And very neatly, they spend less money on healthcare, fewer scans, surgeries, medical treatments, etc. So we're very excited. As of tonight, doing this webinar in, September of 2020, there are 7 systematic reviews and meta-analyses that support the use of pain neuroscience education, specifically for chronic pain. Now, how good is it really? Watch this. When we talk about the efficacy of treatments, we use often the terminology numbers needed to treat. Lorimer Moseley, one of the smart scientists out there, have now shown us if you explain to people how pain works and they get it, in people with chronic pain, the numbers needed to treat for pain is 3 to 1. That means for 3 people with chronic pain, if you explain to them how pain works, the way we will teach you and have taught you, 1 in 3 will be drastically better. How cool is that? Now, you may sit here tonight going, wait a minute, I gave up my whole Tuesday night for something that's only 33% successful. Now, I would challenge you to find other things that is as effective for chronic pain. Do you know what the current best evidence is in medicine for treating chronic pain? It's antidepressants and anticonvulsants. Antidepressants, low-dose antidepressants, will actually turn on serotonin. Your anticonvulsants, your Cymbalta, Lyrica, Neurontin, they calm the nervous system. Right now, gabapentins, NNT, is 6 to 1. Antidepressants, selective serotonin reuptake inhibitors, SSRIs, is about 7 to 1. This is a very effective treatment. Now, there's a slide missing tonight called the NNH, the numbers needed to harm. Unfortunately, I have to report tonight that for SSRIs, there's a high suicide rate. Gabapentin, by the way, can cause significant problems as well. P&E, pain neuroscience education delivered by a therapist, is very safe. We've never had anybody get hurt by it. Now they get mad at you. Oh, you think it's in my head. When you have to try and explain to them, no, this is physiology, biology. And yeah, sure, what you think really matters, no doubt about it. But in this day and age that we're looking at something that's effective, everybody can do it, and it's not harmful, P&E definitely wins this war. I will tell you, this gets me in front of a lot of very important people to talk about how pain actually works. Now, taking it to the next level, you may have heard about the idea of despite the pain, focus on function. Pain is very complex, and to turn pain down is very hard. I need you to understand the most heroic drugs, the most heroic surgeries cannot even do it. So you're not going to just explain pain away from patients. But notice this slide. So I want everybody to look at this slide on the left-hand side. Imagine for a second you got the flu. That is you on the left-hand side. Your pain is high, you hurt all of your body, and the blue line at the bottom says you're on the couch not doing anything. So your function is severely impacted and you hurt really bad. But as you start feeling better, what do? You start doing a little bit more, doing a little bit more, doing a little bit more. Ultimately, guess what? Even though you're still hurting and aching and sore, you're getting better and you move more. That's exactly what happens with people in pain. A little while back, we published the first 3-year randomized clinical trial to track people in chronic pain that we did pain neuroscience education with. And guess what? Pain comes down, no doubt about it. But notice it goes good day, bad day, but it comes down over time. But the holy grail, truly, and I apologize for that statement, but it's kind of that holy grail, as we often talk about, is to focus on function. Despite the pain, I'm going to clean my house. Despite the pain, I'm going to go to the mall. Despite the pain, I'm going to go on vacation. And that is the essence of treating people with chronic pain, having them shift over time. Now, just to get the business side of it, people often ask me, is it something I can bill for? We do use P&E. It's been very well documented. Most of the time, if you sit with the patient across the table and explain to them how pain works, we will bill it as a neuromuscular re-ed. A lot of therapists will often do it while they do other therapy. So if I, for example, do some gait training with you, and while I'm doing gait training, I talk to you about your alarm system is very sensitive. Let me explain stuff to you. I'll probably still bill you for the gait. Obviously not both codes, but I just want to show you this because this is being used all over the country by all kinds of therapists for that matter. I'm very excited also to let you know that pain neuroscience education is finding its way into many EMRs. WebPT, which is one of the biggest providers in the country, by the way, if you click on the tab called Pain Neuroscience Education, it has a whole bunch of the stories we have built, and people click on them. It documents when you do it, and it dumps it into their paperwork. Again, don't get too hung up on this. This is not the intent. I just want you to understand that this thing we build, not only does it work, but we're beginning to integrate it into a system that seems to be working really well with patients, and it's a whole system to try and get it built into the therapy world, if you will. Which brings us now to a very important part, and that is information to behavior changes like throwing wet spaghetti at a brick. The late Bill Fordyce, father of behavioral medicine. We spend in America $2.1 trillion telling people smoking causes cancer, and they keep smoking. Only about 1 in 5 people go, I got it. What I need you to understand tonight, education by itself is not powerful in shifting a human being's a pain experience. You need something else. So in 2016, while we were doing a big systematic review, we actually found something very cool. My colleague, Dr. Corey Zimney, actually came upon this idea. At that point, we were doing a systematic review of 13 papers on using pain neuroscience education, and we very quickly figured out in all of the studies where pain neuroscience was combined with movement, some form of exercise movement, that had a significant reduction in pain. But in the studies where they only did pain neuroscience, there was none of that available. So what does this mean? P&E by itself doesn't work. Not that powerful. And this shows you a great example. So Dr. Joe Nice is in Belgium. He's a very smart scientist. If you want to read his stuff, he's published very widely in physical therapy, in JSPT, etc. One of his colleagues, Dr. Annelien Malfik, did an amazing study with people with chronic pain. Notice this. I want you to look at the orange little block on education. These are people with chronic low back pain. At baseline, they were evenly matched. They then explained to them how pain works. One group, That was the P&E group in the blue line. And another group was taught how their back works, the mechanical, the orthodox way we always do it. Notice that post-education, there was no significant change, NS. They then introduced exercises for both groups, same exercises for both groups. But notice that at that point, the two groups started deviating. The pain neuroscience group started getting better, the other group didn't. And long term, 1 year later, there was still a significant difference. What made the patients better? Exercise, not education. But what the education did is it planted the seeds. And I want you to know today there are 22 different things, and you can study it in the handout, that we have now measured that we do every day that calms the nervous system down. We got to turn on that chemistry in the brain. And this is what we would consider the anti-opioid program. This is the program we're teaching in the VA, Department of Defense, etc. So think of pain neuroscience education more as planting the seeds and then seeing if they can grow in front of us, right? Fair enough. So the final little piece, I want to get into specific to our older adults, because your question probably would be, so, but what does this do with older adults, Adriaan? Well, first of all, just to remind you, I'm not a geriatric specialist. My intent tonight was just to show you how pain works and what the work we're doing in the pain world. But I do want to bring it back to our older adults because I think there's something important. If you look at this slide, classic research that we typically would do would be studies between the age of 18 to 65. If you read most randomized clinical trials, it often excludes people under the age of 18 because of parental consent. And we typically exclude people over the age of 65 because there's many comorbidities we have to deal with. Now, for you tonight, maybe as a geriatric specialist, you should be laughing at this slide because basically everything above 65 is what you will be dealing with, for that matter. So the question is, what about the people that don't fit this 18 to 65 scale? Because most of our research has been on people 18 to 65. Well, let's go to the other side. And I'm just showing you this because I think this is so stinking cool. We have done a lot of work in this area. I'm speaking at the APTA Pediatric Conference later this year. It'll be a virtual conference, but just to show you the neat stuff. So on the one hand of the scale, we decided we build it. Wow, this has definitely been a long day in the office. We built a pain program for middle school children. And we did a whole bunch of studies. I'm not going to give you all the studies in front. This is not what we're talking about. But so we went to kids under 18, right? So these kids are ideally about 11, 12, 13 years old. And you're seeing some of our instructors here, Dr. Jess Padala, Dr. Jen Lorenzo, and they go to schools and we teach them how pain works. How cool is this stuff? Long story short, we've now published 7 different papers. And we've now shown when we teach middle school kids about pain, guess what? Their knowledge of pain goes up. It should. We teach them about pain. They have healthier beliefs about pain as before the education. By the way, they do better than what is currently being taught in school. They're less provocative. What we're currently teaching kids in school about pain, tear, rip, rupture, bulge, herniate, actually makes them afraid. Our program doesn't do that. We've expanded it all the way down to 3rd grade now, between 3rd and 8th grade. And we show reduced physical fear of physical activity in these kids. And then we basically animated this in a video system so we can now take it large scale nationwide to all schools in the country. And very, very cool. We just published it. We taught kids about pain, and we tracked them through school. And guess what? Kids that learn more about pain, 6 months later, they take 30% less pain meds than kids that don't learn about how pain really works. So my point being, it works really well on the young side. We did extend this study, as I said, down to 3rd grade, and I just put up this slide to show you. If you look at the little graph on the left-hand side, grade 3, 4, 5, 6, 7, and 8. So we've taken them to the bottom scale, and we're even doing stuff younger than that now with some board games, etc. So the study was to see how low can you go. Now, I'm putting this slide up for a reason. In the medical literature, when you write content for people, they often say it should be 6th grade and above. Now, in the big study we did with grade 3, 4, 5, 6, 7, and 8, we did clump groups together, and we noticed basically that, yes, there is a difference. There seemed to be a cutoff point. It seems to be, again, right around that 5th grade where kids can really take on this information. So that brings us then to the top end. By the way, I apologize if this picture offends anybody. We, in our office, we loosely call this the Peony Silver program, and I can say that because I'm probably part of the Peony Silver group. The minute you get your AARP card, I think it's okay to go in this direction. So our team has looked on the left-hand side and said, you know what, we're doing some cool stuff for kids, but what about the other side? I have to say we just started some of this stuff, but there are 3 studies I would like to highlight tonight, and then I think we will finish up with all the questions and answers, hopefully. The first one we published a few years ago. Now, this is interesting because many people will look at this study and say, but this is not a true pain neuroscience study. It actually is in some way. Notice the title of the paper, De-Educate to Re-Educate. This little graph I just showed you, we actually tested it in a trial in North Dakota. We went to an outpatient clinic, a couple of outpatient clinics in North Dakota, and when patients showed up with low back pain, we literally just measured a bunch of stuff. I'll show you in a minute. Taught them this simple little thing. As you get older, your back gets older, but back pain peaks here. And we measured if this almost uneducate or de-educate is actually that powerful. Remember, when you teach people about pain, you often have to undo bad beliefs or bad thoughts from the past. And this is kind of a step 1 of a P&E approach. So we took 50 adults ranging from 50 to age 93 years old. Average duration was about 15 years of low back pain, so definitely a chronic pain sample. And they were educated on the poor correlation with aging and low back pain. This little graph we took them through, as I said before, this little graph basically took about 5 minutes to explain, answer a few questions. And so you'll notice it's not a very long, laborious intervention we're doing. It's something simple, easy that can be done in a real clinical setting. Before and immediately after, we measured their low back pain rating, the self-reported rating of low back pain and leg pain, their fear of physical activity, fear avoidance of work and physical activity. We had a series of beliefs about low back pain and aging, and then just their ability to flex forward. So that was our measurements before and after. Simple study. I get it for the scientists tonight. This is not earth-shattering kind of stuff, but it was just testing the hypothesis early on. The results, there was a significant positive shift for low back pain, leg pain, fear of physical activity, subscale for physical activity, and forward trunk flexion. So there were significant shifts afterwards. And by the way, some of these exceeded minimal clinical important difference, especially trunk forward flexion that we found. Now, the discussion for this, obviously the results show that education aimed at altering beliefs regarding low back pain and aging result in positive shift in pain, fear avoidance related to physical activity, and active trunk flexion. So the conclusion, prior to providing patients with new healthcare information like how pain works, P&E, de-educating them regarding poor beliefs may be helpful in shifting them towards new healthier paradigms associated with their condition. So again, early test, simple, I got it, pre-post, not a big of a deal. The second study was not done by me, but somebody that actually I know and has done some cool work. So Adam Rafa and his team did a really cool study a little while back, published in a Journal of Physiotherapy Theory and Practice. And this was more a formalized P&E program, by the way. What Adam did is they took 25 subjects over the age of 65 with a 3-month or greater history of low back pain. So this is 3 months or more for low back pain. Subjects who participated in 2 semi-standardized one-on-one P&E sessions, and they were also given a little booklet to read as well on how pain works. They measured the subject's perception of pain neuroscience education. Did they like the content? Did they understand it? Their gait speed, which is really important in our elderly, pain disability, and then fear of movement. Results afterwards, positive experience with P&E. They liked it. They liked the messages. They understood the messages. Statistically significant positive improvements in gait speed, pain disability, and fear of movement. And very simply, Adam and his team showed that this is very feasible and can be used. So notice again, we're moving in this direction. This then brought me to this idea of cognitions. The question always comes, but Adriaan, can our older patients truly understand this? Remember, in the middle school children, we also wondered, is 6th grade the cutoff? Is 5th grade the cutoff? We're beginning to see 5th grade is kind of that point where they really can take it on. We do know, as humans age, they undergo various changes that impact cognition. And again, age-specific prevalence estimates of dementia increases from 15.7% at age 80 to 84 years to 65.9% at age 100 years and higher. And again, if you're in the geriatric section or you work with geriatric population, these are statistics that you should know better than I do. But there is a cognitive decline, which makes us think, wow, can they really take this on? And that's kind of something we've been thinking, is there maybe a magic cutoff? Can we only do P&E for people, maybe up to 70 or maybe 75 or 80? And I understand, again, be careful of normative numbers for that matter. So before we go into the next slide, there's a couple of slides I didn't add in tonight. Tim Benedict is a student that I worked with at University of Kentucky. He's in the military, serving his country, and he's doing his PhD. And I was helping him with some of his research. And we published a paper a little while back to show that in soldiers with mild traumatic brain injuries from blast injuries, etc., that they also can take on P&E, soldiers, veterans, etc. So there is research with P&E in people with cognitive issues coming through that's beginning to show that they can take it on. So we wanted to test this. Now, if you look at the study by Adam, and again, I want to highlight an amazing study, very proud of them for doing it. They did look at people 65 and older, and they did have an exclusion related to cognitive impairment. They used a 6-item screener, and it has been shown to be reliable and valid for detecting moderate to severe cognition in older adults. And very simply, people that scored a 4 or higher were considered eligible. So people below 4 were not eligible. So they did this, I don't want to say discriminate, but they did delineate between people that were cognitively impaired or not impaired at this point. So we then wondered, well, can they really take it on? And again, it's probably based on Adam's study. So we decided to do a study. This is currently under submission. And we worked with a medical doctor, Dr. Stacy Watson in Michigan, with a bunch of our scientists who did this really cool study. So we went to community centers in Michigan. And this is her, by the way, in these community centers where doctors often come and just do talks about all kinds of topics. She loves the pain stuff. And she basically took adults 50 and above. The reason we did 50 and above is because the community centers opened these sessions for people 50 and above. And we were okay with that, 50 and above. We did a 30-minute P&E lecture, just like the school children, but specifically for our older adults, measured their knowledge of pain, fear of physical activity, and then their beliefs regarding pain, as well as their pain rating. The main thing I want to show you here real quick, as I said, this is under review right now, is that the older group, there was a significant, by the way, increase in NPQ, which is a neurophysiology of pain questionnaire afterwards. So they had a significant increase in knowledge of pain, but only the older group, which was 70 and above, had a significant shift in NPQ versus the younger group, which was really, really cool. It means, wait, guess what? Our older patients can truly take this on. The NPQ, by the way, also shifted for those that were currently in pain versus those who were not. And that makes sense because if you're in pain, you're probably going to pay more attention because it pertains to what you're enduring, if you will. Anyway, there was no significant differences in fear avoidance, and there was some significant changes in questions like, as you age, you will hurt more. And by the way, movement help eases pain, or I hurt because bodily damage is sustained when I was younger. So we were able to shift some of the thought processes. But I think the neat thing is this idea that the older patients actually shifted more. The older elderly patients shifted more than the younger ones, if you will. Last slide, and we'll take some questions. So this is really different again. When you see patients tomorrow in the clinic, in the department, there are only 4 things they want to know from you. What is wrong with me? How long will it take? What can I do for it? And what can you do for it? And again, I think if we look at some of this information we covered tonight, it'll give you an idea again and say, wait a minute, if you go to people and explain to them what's going on, it may seem really complex tonight, but as I always jokingly say, if a 5th grade kid can sit in Wisconsin, listen to a lecture and go, I got it. We know patients can get it. We may have to slow it down, repeat it a little bit, but we can get some really good feedback from them regarding how it works. So with that being said, I am done. I'm not sure if that met your needs or wants. As I said, I'm not a geriatric specialist. I'm a pain scientist. And the idea was just to share with you guys a little bit tonight how pain works. So I am going to do 2 things. I'm going to first of all turn on my camera, and I'm going to see here, I have turned off my screen. Hopefully, you guys can see me in my office tonight instead of just seeing me seeing my screen. And so now, if you have any questions, I see there's a whole bunch of questions. It may be good if you want to put your question in the question box, and I will try and reply and respond to those. All right, so we have your question. I'm going to try and quickly see if I can get this question read here. Question I have here. 1 second as I try to enlarge my screen for a second. It's been a long day it's a long day in the office for me. If I can just quickly get so here is a question. All right, let's see. This is a lengthy one, so I'll just read it. Adriaan, thank you so much, and thank you for including Louw Gifford. He gave me hope to continue as a physiotherapist by his amazing 3 books. Absolutely amazing. Yes. Question: how does the research sit with swelling in terms of some kind of sensitization feature if it no longer acute trauma? And so I'm going to stop that question real quick here. First of all, there is a condition called neurogenic inflammation. You and I were taught that nerves fire in one direction. If I punch you in the arm, the message will fire from your arm to your brain. And we call that orthodromic impulses, right? Fires from the target tissue to the brain and fire in. Something we don't teach you often in school, you maybe were told but forgot, is that nerves fire bidirectional. So if I punch in the arm, nerves fire down the arm as well as up. So it fires bidirectional. When a nerve fires down, or what we call retrograde depolarization, it'll actually backfire and release substance P. Substance P will then cause swelling in an area. With swelling, what happens now, the limb will get a little bit warmer, and it'll be swelling in the area, obviously. And then we start getting histamine release, which will increase sensitization. So what I'm just trying to say, when I see somebody with persistent swelling and there's no new injury or accident, I'm very suspicious of a heightened sensitive nervous system. I will then do a series of tests in the area to see if that nervous system has become more sensitive than, say, the other leg or the arm or the upper body, to see maybe there's a nervous system underneath it that's being driven physically or emotionally that may be driving it. And that has been very well described in neurogenic inflammation. Let's see if I hope I got that whole question there. Ruth, do you have any books or a series of pictures that you recommend using with patients to read on their own? Ruth, these are always tricky. Yes, we have books. I'm not here to sell books tonight. I think you can probably Google those quite easily. A lot of it, I will tell you, I'm sitting in my office tonight. Next to me, there's dry erase boards. Next to me is our clinic. All of our treatment rooms have big dry erase boards with markers. I don't use a lot of it. Necessarily the cards and the pictures I do, but I will draw a lot of it because it's real, it's in front of them. But those are out there. There is a paper, and I can definitely send it onto the geriatrics section that we published a little while back. I think it's now open access on the clinical application of P&E, which shows some of the alarms or whatever. Again, my intent is not for you to go buy these things. They're very well distributed and described, and you should be able to see them even in the handouts that I provided for this. Jeanette has a question here. She says, the biggest challenge I have is when patients have a stroke and they have pain in the hand, sensitivity to touch, and it's very hard to manage. What is the best approach for this? Jeanette, this is a great question. And first of all, again, I don't know. It's something we're going to have to think about on our side because we don't work with that much. Now, having said that, that's not exactly true. There's a couple of things going through my mind. First of all, we have faculty on our research team that work very extensively in the neuro population. And so things we do for that specifically, number one, pain education can work on people if the areas of the brain has not been damaged or hurt that can take that information in. So if the patient is cognitively aware, can understand concepts, we can try P&E. I would very powerfully also teach the family and the caregiver so they understand how pain works. For people that have localized sensitization, say, for example, a hand or a foot, we follow a whole stringent protocol called graded motor imagery, which is a series of techniques that helps remap the brain. And it's things like laterality training, motor imagery, sensory discrimination, sensory integration, so ways we can actually stimulate the area to feed the brain information. We've done some therapy studies on mirror boxes, laterality training with mirror boxes of stroke. There's about a handful of those papers out there. It's definitely more tricky, no doubt about it. And Again, like I said, I'm not a specialist, but some of my colleagues have worked in it. There are some papers on those that have been done. I would almost highly encourage you. You can just, if you want to email me, I can definitely send you a couple of nice articles specifically related to strokes and neuro patients where we've done some of the pain neuroscience retraining. We did a big talk at CSM last year for the neuro section on treating people with neurological conditions and pain. All right, let's see. The next one we have here, Clara. Thank you for the time tonight. Is there a different approach for patients who have already had multiple back surgeries, have severe pain and limited beliefs in the benefit of PT? Yeah, Clara, my PhD work was actually done working with people in pain. In surgery. So my whole work was preparing people for surgery and then dealing with those issues as well. Chronic pain from surgery is probably not that different than others. They have very strong beliefs. They've had multiple surgeries. They've been let down. They don't trust the medical system. Physical therapy probably hasn't done much with them. Tonight's webinar, I want people to remember this. And again, if you want to write it down, you can. Our pain fellows, when they graduate, on a plaque we give them along with their big fancy certificate, we give him a plaque by Theodore Roosevelt, and I want everybody to remember this tonight. He is quoted as saying, people don't care how much you know until they know how much you care. I'm going to say it again. It's really cool. This is tattoo worthy. If you wanted to, this is a tattoo for that left shoulder blade. People don't care how much you know until they know how much you care. So what I'm saying is, if you go into a treatment room and try to explain to them how pain works, they're not going to listen to you, because they've been hurt by the medical system. The biggest thing you can do is probably start developing some relationship with the person, listening, empathy, compassion, etc. We have some amazing research coming through. Corey Zimney, who I mentioned earlier on, super brilliant, smart, one of the smartest guys I know. His PhD work is just about done. And he has shown us the number one thing that makes this thing we're doing tonight work is trust. If people trust you. So how do you build trust? You listen to people. You display compassion and empathy. You get to know them. So all I'm trying to say in a very nice way is, if I had a person walk into our clinic tomorrow with 5 back surgeries, they've been everywhere, nothing helps, he's a 17th therapist. I think the most valuable thing I can do is to listen to the patient and get to know this human being and literally start peeling layers and asking deeper questions and slowly start getting to where they're at. What do they believe? What do they think? What do they think I should be doing for their back? What do they think is going on with their back? Because often there are very bad beliefs and thoughts that are driving a lot of this stuff. But you're going to have to work on getting some of the trust established with that patient. And I'll tell you, we do this all the time. I watch it here in our clinic all the time. We see some of the most complex people walk in, and the biggest aha moment is the minute we start building that relationship. If they can leave that first visit walking out going, that therapist listened, you already light years ahead. Lorimer Moseley, many of you guys may know him, is one of the smartest pain scientists, have said the number one reason this thing works is connection. You got to connect. And that is kind of what I'm trying to get to tonight. I know there's a magic trick, as much as truly wanting to, who are you? What brings you here? How can I help you? Wow, if that happened to me, I'd feel really angry. Validating them. I would encourage you to look at the recent, I think about a month ago, publication in Physical Therapy Journal. There was a beautiful paper, unfortunately I'm on that paper too, written by Professor Joe Neese, NIJS, on combining pain neuroscience education with motivational interviewing, which just shows some amazing questions you can start using to get some of that changed talk into some of our patients, etc. All right, let's see, where are we at? Ruth is asking a question here. Do you think that injuries sustained at a younger age affect perception of pain in the same way later in life? Absolutely. Ruth, one of the biggest predictors of pain is past experiences of pain. If you've had a bad ACL operation at age 17 in high school from a basketball injury, and at age 60 you're going to get a rotator cuff repair, the odds are against you. Past experiences predict future experiences very powerfully, and the same thing happens with pain. So we need to be careful. That's why the really good surgical centers do very strong psychological profiling on people before surgery to make sure some of the past experiences may not carry over. So yeah, it will definitely make sense how you experience pain, no doubt about it. All right, Casey, I was not familiar with the idea that neurons turn over every 3 weeks, and the idea that 1,000 neurons per year. Is there a good resource or article? Casey, I'll have to go look that up. The research came from Stanford University in 2001. I got to go find that research. The 125,000 miles of wiring that changes, that's widely just published. And again, same thing. If you look at most of the neuroscience literature, there's good validated research that brings that up, no doubt about it. I've always believed there's significant cognitive decline with the loss of neurons, but the research shows actually we can keep growing neurons in advanced ages over time. That's from Stanford University's research again. As I said, you can probably, in this day and age, you can probably Google most of it, but I can probably, if you email me, we can try and find you that reference as well. All right, Catherine, some of the patients we see are already on gabapentin and other pain meds. How does that affect P&E? Catherine, gabapentin is not a bad thing. Our clinic, we see about 30% of our patients have CRPS, which is one of the worst pain conditions you can treat. And all of them are on gabapentin or something related to that. We would not be able to treat them without that. They're so incredibly sensitive. So I don't want to say it this way because this is very scary, but if you look at all the drugs we can give people, this is probably on the safer scale. It's better for therapy because I can touch people like that. I can work with them. I can do physical activity. So it's a little bit better if these patients are on them. Some of these patients will have to be on it for life. It's between them and their physician. My goal is, can I make their life so much better that the doctor can taper the drug down, potentially even taper completely off. But I have no illusions that there are a percentage of my patients will never be off it. And that's just, it is what it is. But if with gabapentin, maybe a lower dose, with some good self-management strategies of sleep hygiene, exercise, and all those, they can get to a very functional level. I think we're in a good spot for a lot of these patients again. All right, Devin, you're asking me what article again? I'm sure if I missed something, I'm not sure which article we're referring to there. All right, Jeanette, I am very interested in learning more about P&E. Jeanette, there's a lot of it out there. Again, like I said tonight in my disclaimer, I'm not here to sell anything. If you want to Google any of it, you can. You can Google me for that matter. There's other people doing it as well. We've done quite a bit of P&E stuff at CSM. Most years I do at least 2 sessions. I think coming up for the virtual CSM next year, I'm actually speaking for the geriatrics section, so I'll be back unless you guys vote me off the island tonight. But there is some information out there. There's articles, etc. Or you can email me afterwards, and I can send you some stuff you can read if you will. All right, Marnie, easy question for you. I love these, yeah. When do you think this understanding of pain neuroscience will truly mainstream and adopted in the spheres of medicine, especially orthopedics? Marnie, it's a great question. First of all, it is under CAPTI review. We know that one of these days it'll be in CAPTI required curriculums. A lot of schools are teaching it. That's in the PT side. So that's good news. I am doing a lot of research right now in physician assistant schools. We've got some papers we have published and it's coming out soon as well. We're teaching it in medical schools. I speak at more medical conferences and PT conferences. So there is a moving of the needle somewhat. But we need more of you out there to do this and push this out. It's getting there. I'm actually scheduled to speak to the chief medical officer of United Healthcare tomorrow, and next week is Humana Healthcare. So there are people in the bigger scheme that's listening to us. This program the stuff I taught tonight is being taught now in every VA, in every Department of Defense. We're teaching it. So I'm an optimist. So I'm seeing a lot of good. And so hopefully I still can stay healthy long enough and not too old and get a lot of you out there to help us. So I'm positive. I'm seeing it. I'm seeing a lot of pain docs are talking about it. I'm seeing psychologists, psychiatrists. It'll be interesting to see. I'm excited. So, yeah. All right. Minute or two left here. Maura, how effective have you found PME to be with clients who have CRPS? This population is extremely challenging with clearly many psychosocial impacts as part of the medical experience. More of the current best evidence for treating CRPS is graded motor imagery, and that's a sequential series of techniques we use to remap the brain. So, and in the sequence is P&E. Graded motor imagery, when it came out, we did things like laterality training, we did things like mirror boxes, we did sensory discrimination, sensory integration, motor imagery, those are all perfect. But you have to first explain to the patient why they're hurting and what's going on. So we have done CRPS with people in P&E. We have a study coming out. I know it doesn't help you tonight, but we did a brain scan study on a lady with CRPS, a very bad case of her hand, that showed the brain beautifully calming down. So it is very effective. Remember, pain is pain. The brain doesn't care if it's coming from the back, the neck, the knee, the shoulder, where it just knows I'm under threat, it produces pain. So there's always value in making any person with pain understand what's going on. It can get better. This is what I can do for you as a therapist. This is the stuff I want you to work on at home. Kind of that last slide. But you are correct. CRPS is challenging, no doubt about it. But it's also an opportunity to really impact somebody's life. Fair enough. All right, Aileen, do you know of any P&E research being conducted in a skilled nursing facility environment? Aileen, unfortunately not. And we're doing some work in the acute care environments. We are doing work, as I said, in community residential care facilities. We haven't done skilled nursing units yet. Right now, it's on our to-do list, if you will, especially a lot of upgraded motor imagery work, but COVID has put a little bit of a damper on it. And no, I don't want to blame COVID. We have a lot of work, so research is full, and we just begin to veer in this direction. So hopefully one of these days we will have the right places to start doing it. All right, James, I think I'm going to give you the last question just because I've been in the office for a long time. My kids probably wonder where I am, my wife. I probably should get home at some point. So, James, you said patients with acute pain needs P&E. Is this because they have chronic pain support group in my PACE program? Sorry, let me read it again. Let's see, is it Caitlin? Maybe I missed this. Wait a minute. Here we go, James. All right. You said patients with acute pain need P&E. Is this because they have psychosocial issues and concerns? That's a good question, James. We have published a paper last year in the Journal of Manual Manipulative Therapy where we took 80 people with acute low back pain and we just taught them these stories for about 15 minutes, acute care, how it works, and then we remeasured. About 1 in 4 was drastically better. And I think what it is they come in because they have catastrophization. Woe is me, life is over, I got back pain, life is over, right? Or they have high levels of fear of work or physical activity. We know those yellow flags are present early on. So I think it's that mixture of people with acute pain, but they also have the psychosocial risk factors. So that would make sense. I would argue that if somebody had just low back pain but no fear or no catastrophization, that probably wouldn't do as well with the cognitive intervention. They'll probably look at you like, what the heck are you doing? I need you to do work on my back, right? So yeah, it's probably part of the subclassification categories that we're definitely doing. All right. Caitlin, as far as doing P&E in group settings, yes, it's been done, it's been published. The biggest challenge for groups typically is billing in an outpatient environment. It's being done a lot in hospital systems. So what happens in group settings, patients meet once a week. A session lasts about an hour, 8 patients typically. The psychology research says you cannot do more than 12 at a time because the groups get too big. You have to control them. 12 seems to be the magic number from the psychologist. They meet once a week for 8 weeks, an hour long of P&E, but then they also get other things added to it like stretching, they get breathing, they get mindfulness meditation. So it's not only P&E, it's P&E plus something else. So it's P&E. So week 1 is P&E plus mindfulness. Next week is P&E plus exercise, and then it's P&E plus, and we keep adding stuff to the program, but it has been done quite a bit. All right. All right, I hope that fills in. We could probably sit there all night. I could, but it's just been a very long day in the office. I think you all need to get some rest as well. I want to thank everybody for coming. Thank you for hosting me. My email should be on the last slide, and I can also make it available. Feel free to email me. Truly, we have a team that can give you a lot of articles and references. If you need any advice of any of those, we'd love to help you. And Rolando, thank you for inviting me. I hope you guys come out tonight and get some rest. Get away from this stuff and hang out with your family tonight and maybe get some downtime.
Thank you. Good night, everybody.